Welcome to the new and hopefully improved unRemarkable labs. We're really fortunate to have one of my colleagues, Dr. Angela Goffo, who's the head of rheumatology at the Birmingham VA and part of the division of rheumatology overall at UAB, to talk about rheumatological testing, which remains a bit of a mystery to me and seemingly to most of the students, house staff, and colleagues that I work with. Fortunately, Angelo is outstanding at explaining this, and hopefully these two episodes will help you. Angelo, why don't you just introduce yourself briefly?
Thanks, Well, thanks for the invitation. Always, I'm a rheumatologist. I'm the chief of rheumatology in the VA in Birmingham, and also one of the associate program directors of the fellowship in UAB. I'm a graduate from UAB and did the rest of my training in rheumatology in UAB. So always pleased to be here. My areas of expertise are usually gout and complex autoimmunity, including vasculitis. But it's a big pleasure to be here.
And you ought to mention, in case they notice an accent, why you have that accent.
Because I grew up and I trained in Lima, Peru. So that's where I'm from. I'm very proud of the accent. I cannot shake it out. But yes, that's where it comes from.
I wish I had such a good accent. Now I think it'd be great if each of our residents would briefly introduce themselves. I guess we'll go with Nikhila first.
Hi, I'm Nikhila. I'm one of the second year medicine residents. So I am actually from Atlanta originally, but did school in St. Louis for undergrad and med school, and then kind of moved back home or closer to home for residency. And it's been a good year and a half here at UAB.
Great. Julie?
Hi, I'm Julie England. I'm also a second year medicine resident. Grew up on a farm in Texas, went to med school at Texas A&M, and now I'm here.
Sandkelp?
Hi, my name is Shankalp. I'm also a second year medicine resident. I grew up in India, and I might also have a different accent, so you know why. And I did my med school in India as well, moved here for residency.
Excellent. Malika?
Hey, I'm Malika. I'm an intern at WashU in medicine. And
Excellent.
I'm from Richmond, Virginia, and I did med school there at Virginia Commonwealth University.
As did I.
Really?
Yeah.
Oh, wow.
I went to Douglas Freeman High School.
Oh my gosh. Okay. I grew up around there. Yeah, nice.
Cosette?
Hi, I'm Cosette. I am a second year internal medicine resident at WashU. Came from Duke for med school. I may have to jump on and off in just a moment for clinical duties, but was hoping to listen in and can hopefully join in the future for further episodes.
Great. And our fearless leader, Natasha, why don't you introduce yourself and start presenting?
Hi, everyone. I'm Natasha. I'm a second year resident here at UAB. And I'm originally from Memphis, came to UAB for undergrad and just have never left because I love it so much. So we can go ahead and get started on presenting this case. I'm going to go ahead and share my screen with you guys. So the one-liner on this patient is a 22-year-old female with a history of hypothyroidism. She is coming into RED at UAB, presenting with some shortness of breath and, as she describes it, a couple of months of worsening diffuse swelling. When the ED gave me a call about this patient at that time, her vitals were most remarkable for a heart rate of 133, as well as an oxygen saturation of 94% on 4 liters of nasal cannula. I'm going to skip down to her labs, which were largely unremarkable when the ED did call us. She had a creatinine of 1.0, which, for a 22-year-old, you might consider that a little bit abnormal, but technically it was in the normal range. And I know Dr. Centaur likes to comment on the BMP. She did not have an anion gap. Her bicarb level was within normal limits, as were all of her other electrolytes. And then her CBC was remarkable for some thrombocytosis. And then I can give you her exam for when we went down to see her. So she was diffusely anasarchic in moderate distress, mainly due to work of breathing. She said that she was very, very anxious and feeling short of breath, and attributing it more to anxiety than true dyspnea. She also had some periorbital edema. Her face was pretty red, and as seen in her vitals, she was tachycardic. She did have normal rhythm, was regular, and then she had 4+ pitting edema all the way up her thighs and her lower extremities. In terms of her pulmonary exam, she had decreased breath sounds bilaterally, and we already talked about her increased work of breathing. Her GI exam, she was soft, non-tender, non-distended, but again, just kind of diffuse anasarca. So she did have some fluid on her belly as well. And then for her skin exam, we noticed that her skin felt thickened throughout. So I will stop there and ask you to comment.
So, Angelo, how do you think about this particular patient? And you do inpatient ward attending, so it may or may not be rheumatology, but let's give it a rheumatological bent. And I guess the biggest thing here is skin thickening throughout, but there are a lot of other things going on.
Yes. So you first try to, for me, that I come being a subspecialist, you need to try to detach yourself from that. But it's inevitable that you will come back to that. You know, you think about why someone this young will develop such a serious illness, because she's obviously very, very sick. And when you think about the conditions that can affect young adults this way, and would give you generalized edema, essentially, immediately what comes to mind is systemic lupus, which tends to be a condition that affects predominantly young adults, usually more young women, although it's interesting that when lupus affects men, usually young men, if you compare young men with young women, it tends to be more severe in young men. So when you see a young, an adolescent or a person in his 20s with lupus, if it's a man, it tends to be more severe with more nephritis, more internal organ involvement. A young woman with lupus can have basically fatigue and arthralgias, and still pretty kind of annoying illness to have. But when we talk about internal organ involvements, you know, I usually am more scared of young men with lupus than young women. But no, in her case, no, you could think about lupus with lupus nephritis, with nephrotic range proteinuria, and that leading to anasarca and generalized edema. That's what the physical exam implies. The physical exam, you know, periorbital edema is quite characteristic of nephritic syndromes, and you have, of course, a lower extremity edema with pitting, which is characteristic of also nephrotic syndromes with heavy proteinuria. The decreased breath sounds, I imagine, are a consequence of pleural effusions, because that's what you usually would present as decreased breath sounds in this context. You know, like you can think also about pneumothoraces and something else, but in this context, you will think about pleural effusions. The skin thickening is what kind of makes us kind of could offer other items in the differential diagnosis, essentially systemic sclerosis, and And here is where more history needs to be obtained, because for systemic sclerosis, the fundamental question is Raynaud's. Systemic sclerosis has two main flavors, diffuse and limited. It's someone who has skin thickening throughout. You immediately think about diffuse, because limited scleroderma tends to involve hands, forearms, usually doesn't go past the elbows. So if you tell me that the skin thickening is diffuse and throughout, then you think about diffuse. Diffuse scleroderma cases, the Raynaud's can start along with the skin thickening. In limited scleroderma, usually the Raynaud's tends to precede the skin thickening. But patients with diffuse scleroderma, when the presentation is quite sudden and dramatic, can have a shiny edematous skin that can appear to be like swelling. So actually they have swelling in the hands, and they have a very edematous skin, and that usually is the initial phase, and then that tends to be replaced by the characteristic woody, leathery thickening that you probably have seen in textbooks in scleroderma. So you have here two items in the differential from the rheumatological perspective. Another observation there in the labs. The labs look pretty unremarkable, with the exception of the platelets, which are mildly elevated probably, and elevated platelets sometimes is a surrogate for high inflammatory states. So usually it correlates with high inflammation, like the sedimentation rate, or you can see also thrombocytosis with iron deficiency anemias, and of course in primary platelet disorders, but it can be a surrogate for high inflammatory states. Other items in the differential in this context, you could think about a systemic vasculitis with glomerulonephritis. Comment about that is that usually systemic vasculitis that present with glomerulonephritis, they can give you proteinuria. It's not usually heavy proteinuria like nephrotic rage proteinuria that you can see in lupus. So to explain the diffuse swelling in the lower extremities, potentially causing anasarca and pleural effusions, I will have a much harder time doing that with a glomerulonephritis induced by a systemic vasculitis. And we're talking here about ANCA vasculitis, IgA vasculitis, and cryoglobulinemia mainly, like the ones that cause glomerulonephritis. Sometimes we see patients with the myositis subtype that now is called antisynthetase syndrome, that can have also arthritis and edema in the extremities, and in lung disease. This description is much more consistent with a pleural effusion than with interstitial lung disease. But you can imagine someone with bad interstitial lung disease, pulmonary hypertension, and then lower extremity swelling. That will explain shortness of breath, and certainly a lot of the swelling. Diffuse scleroderma also could have ILD and pulmonary hypertension. So those are my initial reflections about the rheumatological differential. Of course, you could offer other items in the differential for the perspective of general medicine, but thinking like a rheumatologist, this will be my initial considerations.
So I'd just like to add that Natasha pointed out that the creatinine is 1.0 in a 22-year-old woman. And that is within the normal range, but I doubt that it's normal. And that would be consistent with your hypothesis that there's a glomerulonephritis with a strong nephrotic component. I agree 100% with the periorbital edema, and the diffuse anasarca makes you think of renal involvement. Once you start thinking of renal involvement, that takes you to rheumatological diseases very often. So one of the things that and I'm going to let ask the residents to put anything in the chat here, any particular questions they have for you. But as a resident, when you get an admission like this, there's a tendency to just order everything. Would you order everything at this point, Angelo, or are you going to order targeted things? And you already mentioned that you want to go back and take a more history. And I thought that was really great that you wanted to find out whether or not the patient might have had Raynaud's to put you down the systemic sclerosis pathway. But how do you think about ordering labs in a patient like this?
I would say I would probably start with a core set of autoimmune laboratories. For example, I was mentioning a few minutes ago antisynthetase syndrome, and that usually the way to test for that is an 11 antibody myositis panel. I probably wouldn't go there in the first round of laboratories. That would be guided, but if an initial round of laboratories, for example, for approaching the most common possibilities here, I'm thinking about lupus and probably systemic sclerosis. I would like to see her urinalysis, of course, and that will inform me how much proteinuria she has, and I would like to see her. Her inflammatory markers, and I would like to see probably a set of laboratories for lupus, which will include an antinuclear antibody, will include an anti-SSA, anti-SSB, that are also known as Rho and La, probably a DNA antibody, and Smith and RNP antibody. I will probably do that panel for lupus because it's a strong consideration for me. If the story tells me that there is an important component of Raynaud's, and there is on my physical exam, I will look carefully for friction rubs that usually you can find in the ankles and wrists. And if the picture is very consistent with the scleroderma, I would like to add probably a panel for scleroderma, which will include an anti-topoisomerase 1, also known as an SEL70. I would look carefully at the pattern of the ANA, looking for a centromere pattern of the ANA that will be supportive of limited scleroderma. And there's a new antibody for scleroderma that is called RNase polymerase 3 that is associated with very severe rapid presentations, usually including a pleuropericarditis, and I will probably order that test again if my physical exam is leaning in that direction.
So I think the urinalysis, I would suggest an albumin just to document that we're dealing with hypoalbuminemia. Do we have those basic tests? And I would love to see a chest X-ray as I'm trying to make go through the decision making. What can you give us, Natasha?
Yeah, so I can just start with a little bit more history. I think that would be good, and then we'll go to labs from there. So essentially, in talking to the patient and asking, once we thought that something rheumatological was going on, we went back and took a little bit more history. So she said about 4 months prior to admission, she started to notice some facial swelling, and her mom gave her Benadryl for it, which didn't help. She thought it was some kind of allergic reaction, and she ended up developing kind of edema everywhere and noticed some swelling. They took her to her PCP, who just did some basic tests, and she was found to have some vitamin deficiencies. She said at this time she kind of lost her appetite and wasn't eating very much, so she was put on a multivitamin for repletion. In the months leading up to her admission, her swelling progressed so much that she felt like she didn't have any mobility, and also ended up developing some joint swelling and skin tightness, which made ambulating painful. So she actually became wheelchair dependent by the time she was admitted. And despite all of the swelling, she also had an unintentional weight loss of 20 pounds, despite all the fluid she had. And then a more specific rheumatological review of systems, she did develop some joint pain and swelling like we talked about. And then when we asked specifically about if there were any changes in her fingers with the cold, she did endorse her fingers turning purple and then white in the cold. So she was experiencing symptoms consistent with Raynaud's. So in terms of labs, I'll start with the urinalysis. So she had, interestingly, 1+ protein, 3+ blood, and then her urine protein to creatinine ratio was 3.26.
Let me just stop you there and make a point. There's a very interesting article in the Annals of Internal Medicine about using the urinalysis protein to predict what the 24-hour urine protein would be. And it has really wide confidence intervals. So the 1+ protein should not sway you against this being nephrotic syndrome and getting the urine protein creatinine ratio. The nephrologists really prefer urine albumin creatinine ratios, but we usually don't get that. But then as the albumin comes up and is low, we suspect a nephrotic range. Dr. Gaffo pointed out that the periorbital edema almost is just the biggest clue in the world that you're dealing with nephrotic syndrome. The 3+ blood is consistent with his hypothesis that this is a glomerulonephritis. Is probably both a nephritic and nephrotic combination. And then the chest X-ray is as Angelo had predicted. What are your thoughts now, Angelo?
Yes, I am. I am more reassured that we're dealing with a glomerulonephritis. I am also curious now because the clinical description, the story, is starting to make sense for systemic sclerosis, and there's some arthritis, apparently severe restriction in movement, the description in the physical exam of skin thickening, and Raynaud's. Raynaud's can also happen in lupus and other autoimmune diseases, but if you think about the renal involvement in systemic sclerosis, it's not typically glomerulonephritis. Is not, many of you may have heard about scleroderma renal crisis, which is a different phenomenon. It's a vascular phenomenon involving the kidney. But usually scleroderma is not commonly associated with primary glomerulonephritis unless there is some kind of overlap syndrome, which can happen. Now we see not uncommonly two overlaps between scleroderma and lupus, or scleroderma and other connective tissue disorders, myositis, and some of these can have a glomerulonephritis. But I would not expect initially, not my initial expectation that a case of diffuse systemic sclerosis will have this type of renal involvement. I would expect, you may remember scleroderma renal crisis, hypertension, sometimes some microangiopathic hemolytic anemia, rising creatinine, very responsive usually to use of ACE inhibitors. But I am just curious about the putting together what I'm hearing from the history that tends to be most consistent with diffuse scleroderma, with what we're seeing in that renal involvement mainly, which is most concerning for glomerulonephritis.
Any questions from the residents before we get some reveal on the rheumatological testing? That just tells me that Angelo's doing a great job of explaining, which he always does. So let's get the big reveal. Is there lupus here? Is it mixed connective tissue disease? Is it systemic sclerosis? And once we get the lab results, Angelo, tell us how you think about those lab results.
Okay, I'll give you the lab results and then I will follow that with a little bit more history because our clinical course got a little bit more interesting. So in terms of her autoimmune labs, we ended up getting the ANA came back at 1 to 320. It was speckled in nucleolar. Her SCL70 antibody was negative. And we ended up, for reasons I'll get to in the history in a minute, getting some muscle markers as well. We got a CK level, which was elevated at 11,500. Aldolase was 350, and then LDH was 962. I don't have it written down, but I'm pretty sure her SSA came back positive. One of her Sjogren's antibodies came back, but essentially everything else was negative. Anti-Smith, anti-double-stranded DNA, and then all the labs that Dr. Gaffa was talking about for scleroderma as well, even some of the newer ones. And we ended up sending the myositis panel further into her hospital course, which also came back pan-negative. So to go a little bit into her history, so she got admitted, she ended up on BiPAP for worsening respiratory distress, and given how young she was, we were hoping to stave off intubation, but she became progressively weaker and was just having trouble taking breaths at all, and ended up getting intubated pretty soon thereafter. And at this time, there became more of a concern for a myositis picture as well, causing diaphragmatic weakness. Her urine output ended up dropping off, her creatinine sharply rose. She became hypertensive, consistent with scleroderma renal crisis. She got started on captopril. Unfortunately, she did end up on dialysis for several months. And she also developed, she ended up having a renal biopsy a couple of months into her hospital course, and it was actually consistent with TMA as well. So she essentially developed every complication possible. I think Dr. Chatham was the rheumatologist on service for part of her course, and I think the ultimate diagnosis they gave her was scleroderma with myositis with SLE overlap. And I'll let Dr. Gaffo explain kind of why that is. Okay. Very complicated diagnosis, but you were right on point, Dr. Gaffo. You called it.
Well, these complex autoimmune overlap syndromes are extremely challenging, and you always want to apply you want to kind of unify everything under a nice single box, but quite often that's not possible in medicine in general and rheumatology in particular. There are very well-known cases of scleroderma that can have an important myopathic component. And same with lupus. Patients with lupus can have significant muscle inflammation and myositis. Now, but the question here is if this patient has a primary myopathy, like the one you see in what we used to call polymyositis, we don't know what that is anymore, or dermatomyositis, and it's a true overlap between that disease and scleroderma, and who knows, possibly lupus. The myositis is an evolving concept. Now, again, I was mentioning a kind of joking, polymyositis is we don't know what we're talking about anymore because it's disappearing under the big umbrella of antisynthetase syndromes, which include the one associated with JO1, with a number of other autoantibodies, PL12, PL7, MDA5. So all of these are developing more distinct syndromes that involve what we used to call polymyositis in general. Dermatomyositis is a different defined construct with the rash and with a probably more benign evolution. This patient obviously had a myositis. I'm having a harder time diagnosing her with a specific myositis, a specific syndrome as defined by these autoantibodies that we're talking about. So I think she probably has scleroderma or lupus or an overlap between them two with a strong component of myositis. So that's how I define it better. But it's certainly quite complex. The renal involvement also is confusing for me. A TMA in the kidney, I wouldn't expect it to give you 3 and change grams of protein. So I would say first look, this patient had a glomerulonephritis, and that's not being described in the renal biopsy report you mentioned. So it's pure TMA, which is most consistent with what you will see in the scleroderma renal crisis. Often the hypertension component is not mentioned in those vitals. I don't know if that happened later. You will expect to see hypertension.
It did happen later. Sorry, it was a progression. So when she came in, she had basically hospital day 4 was consistent with a scleroderma renal crisis, which the biopsy also did show later. And the TMA was about 6 weeks into admission. She ended up being hospitalized I admitted her back in May and she got discharged, I believe, in October. So she was with us for quite a while.
And you can imagine the terrible struggles of the teams caring for her, because what's your first reaction when you have a patient like this? You suspect terrible lupus and glomerulonephritis, and you give them steroids. And what are you not supposed to do with patients with a scleroderma renal crisis? Give them steroids. Actually, prednisone in doses higher than 10 milligrams or are supposed to precipitate scleroderma renal crisis. So so this is a terrible problem to have. Well, I think from the point of view of the diagnosis specifically, my best bet is somewhere between lupus and scleroderma overlap with a strong myopathic component.
So Angela, I hope I'm speaking for the residents. That ANA of 1 to 320, how do we interpret that? And does that confuse the picture, or would anything confuse the picture, because this doesn't fit neatly into one of the rheumatological diseases that we see separately, because we keep talking about overlap?
Well, an ANA of 1/320 is kind of what we will see as medium titer. But this is a lot of this has to do with clinical context. Normally when I get a consultation for someone with fatigue and joint pain, and I see an ANA, they send the patient to me with an ANA of 1/80. I tend to be very kind of skeptical of the value of that ANA. Because ANAs in ranges of 1/40 or 1/80 are quite common in the general population. But if I get a patient like her, with a clear autoimmune picture, even an ANA of 1/80, it's telling for me. We even see cases like these in which the ANA is negative, and that's sometimes very hard to explain, because you expect most patients with active aggressive autoimmunity, especially of the lupus type, to have positive ANAs. I think her ANA of 1/320 is consistent with the diagnosis. You can see ANAs of this titer in lupus, active lupus, and scleroderma too. What offers actually a little bit more value to her ANA is the pattern too. Her ANA was described a nucleolar pattern. Nucleolar patterns tend to be more specific for autoimmunity. Not the major patterns, homogeneous and speckled. Those two are less specific. In high titers, they have value, but in low titers, they have less value. But nucleolar and centromere patterns tend to be more specific for autoimmune disease that is significant. So in this case, 1/320 nucleolar, I think it's consistent with what I'm seeing here.
So let's do this. I'm going to ask each of the residents to tell us the two most important things that they're trying to take away from this discussion. And Angelo, they may have something confused, because I do this all the time and residents have things confused. So I want you to reinforce what they say, or teach them what you confused them on the first time. So I'm going to start at the bottom here, if I can figure out where the bottom is. I think it's Nikila.
So I think one of the kind of take-home points I'm taking away from this is really the kind of the pattern for the ANA that we just kind of talked about. That was really kind of striking for me, and to know that the nucleolar type is kind of more specific for an autoimmune condition. And because I feel like I just got off of the rheumatology service last month, and we saw a few that were like speckled, but I didn't really know what to really make of it. So that's something that is really helpful for me. And I think kind of also a big take-home point, another take-home point for me is that I think especially in rheumatology, looking at kind of like, I know we're going to talk about this a little bit more in kind of the next session, but kind of the rheumatological labs and how I tend to kind of box off, like if it, like what I'm trying to say, I guess, is like, if the AN is positive and this is positive, then it's this, but just kind of knowing that it's all a kind of continuum. And there's kind of this mixed pattern that can kind of explain everything that's going on without kind of fitting into this nice, neat, perfect box.
All these tests have value within a context. That's the main message I wanna pass to you. Now, there are tests that are quite absolute, like sometimes when you see there are some antibodies that carry a lot of value, even out of context. There are few of those. Most of the rheumatological tests and medical tests in general, they are framed heavily within the context of where are you checking them. In the context of this person that has obviously a very serious autoimmune disease, even an ANA of low titer carries more value than in someone who is sent to your clinic with an ANA of 1/160, let's say, and back pain. That actually, that the clinical correlation is not there. So that's when you sometimes think about a false positive. Always pay attention when you look at the ANA test to the titer and the pattern. Between them two, and of course, what's the context in which it was checked. And that's what gives you more information and it helps you frame it better.
That is such a wonderful description of understanding the patient and why you got the lab test. That was beautiful, Angelo. Malika.
Yeah, so I think the first point is pretty similar to what was previously mentioned, just kind of being comfortable with these overlap syndromes and not having like one diagnosis that has like a name that's defined, but kind of being okay with the overlap. And then secondly, kind of looking at that urine analysis. I think the study that Dr. Centaur mentioned about that initial protein load on the UA not necessarily being indicative of like the total protein in the urine, and just kind of being sure to follow it up, urine protein creatinine ratio or 24-hour urine.
Yeah, so and I think the key here is the clinical, this is again a context thing that Angelo just talked about. The clinical context here looks so much like nephrotic syndrome that checking an albumin and checking a urine protein creatinine ratio, even without the urinalysis, although I think you needed the urinalysis, would have been indicated, even if there was no protein, you'd still want to get a urine protein creatinine ratio. And the 3+ blood certainly was a big clue. And now Natasha didn't tell us how many red cells there were, whether any red cell casts, but I won't get too picky. Julie.
So a couple of good ones have already been mentioned, so I'll try to mention a few others. One thing that I think is always a good learning point for me is paying attention to the progression of a patient's disease. So seeing, when she was first admitted, she wasn't hypertensive and her creatinine was only 1, but then she clearly progressed in the span of those 4 days. And I think that can kind of you can learn a lot about like how a disease might present at different times, or what a diagnosis might look like early on as opposed to late. So that was a good learning point for me here. And then also just the brief discussion of treatment of scleroderma renal crisis, because that's something that I haven't treated before.
Yeah, that's it's very challenging sometimes, because you probably learn very early in med school or in your first experiences that scleroderma renal crisis, no steroids, and captopril, like, but sometimes it's not very obvious. One of the biggest blunders of my early career when I was young faculty is I gave more steroids than I should to a patient with a scleroderma that I didn't recognize early enough, and I precipitated a scleroderma renal crisis. So sometimes it's subtle, it's confusing. So if you're not paying attention to subtle clues, like candidema, the Raynaud's, things like that can point in that direction, it can happen. So we're seeing less scleroderma renal crisis in general. So we don't understand why is that. Probably we're taking better care of these patients in general, or probably the more generalized use of ACE inhibitors in general in the communities doing something to make this a less common presentation. But yes, this is something that it can be a simple answer when you recognize it, but it's sometimes hard to recognize early on.
Sandkelp.
Well, I think most of the learning points were covered, and I agree with all of them. I think this case had a lot of things to learn. For me specifically, apart from the things that have already been mentioned, I was not actually aware that this degree of myositis could happen with scleroderma. Like, we don't usually read it very commonly, and especially such a degree causing a patient to get intubated. I'd never heard of it. So I think that is something I'll keep on the back of my mind. Also about the antisynthesis syndrome and the fact that polymyositis is now divided into these various groups, and we have more specific things going on. I think these are things to always keep in mind, because we usually just think of dermatomyositis and polymyositis, nothing beyond. So that's definitely an interesting concept.
Yeah. Yes. I was trying to organize my thoughts about your very interesting points. Yeah, polymyositis is an evolving concept, and that's it. Something that has changed dramatically since I was a fellow until now. It was very, you had the myositis, where polymyositis, dermatomyositis, inclusion body myositis, and now the dermatomyositis is still a very well-defined entity. Inclusion body is also a very well-defined entity. but polymyositis has turned into something unrecognizable because first the necrotizing myopathies got better defined within polymyositis. Many of them are associated with use of statins and with the generation of an antibody that specifically targets the statin pathway, and several other anti-synthetase syndromes have been much better defined clinically and by the antibody response. So, and you could correlate that with different clinical presentations, the ILD, the myopathy. Some polymyositis don't have myositis anymore. They just ILD and arthritis, and so it's a very interesting evolving field, and it's very fascinating to work in that field nowadays.
Yes, so Malika has one more. This will be our final question, which I think is a great one. If you'd seen this patient on the first day and she was admitted to your service and you had that CK and aldolase, would you have considered a muscle biopsy?
Yes, I would have considered a muscle biopsy. It seems very interesting. The question is very timely and very interesting. The role of muscle biopsies is being reevaluated very dynamically right now in this. A muscle biopsy, it's a test that usually is preceded by some kind of imaging or electromyogram test to identify if the pattern is consistent. So probably this patient would have had a muscle MRI or an EMG to confirm that there is a pattern consistent with an inflammatory myopathy, and then the muscle biopsy would have followed. I think if the question would have been an inflammatory myopathy of the dermatomyositis type, or versus a different type of myopathy, a muscle biopsy could have had a role. I see that less clearly in this case because I don't know what influence in the management the muscle biopsy would have had for me. We know this is not dermato, so this is not going to look like the perifascicular myositis. We know this is probably very, very likely this is not a necrotizing myopathy. So the answer probably would have been, there is muscle inflammation and within the fascicle, and that would have been the answer, myositis. And how would that change my management in a patient that has probably this very severely ill otherwise? I wouldn't see it clearly. So the test again is not done in isolation; it's done in a context. And probably in this case, I assume probably I would not have required a muscle biopsy to guide my management further. That's the best answer I have for this case. I still do muscle biopsies in patients in which I suspect polymyositis in a different clinical context. Some people are not doing muscle biopsies anymore. They don't see it as such a useful test anymore. If you have a consistent antibody and a very consistent clinical picture, probably and consistent electromyogram or muscle MRI, but I still find some value in them personally.
So Natasha, why don't you take us home?
Yeah, so this case obviously had a lot of learning points for me. This was one of my second to last month of intern year. When I initially admitted this patient, I thought anasarca, concern for glomerulonephritis, this is probably going to be lupus. And then when I called rheumatology and talked through the case with them, when they came and saw her, I think that was probably the first time, you always hear that rheumatology isn't just about the labs, it's about the clinical context and things like that, and choosing which labs to order and to be deliberate, because typically if you order enough labs, something can pop positive as a false positive, and to be careful with that and really to take the patient's clinical scenario. And then just in terms of, scleroderma renal crisis, it was something again, in med school, you learn about the captopril, and I think she initially had gotten steroids to try to save her kidneys from the glomerulonephritis aspect. In turn, we ended up precipitating scleroderma renal crisis and then gave her captopril. So it's definitely a balancing act. I think it's the case because one, it has the good learning point of rheumatology is a spectrum. And I think there are a couple of attendings at UAB that will argue that scleroderma and lupus are on the same kind of opposite ends of the same spectrum. So it just depends on who you talk to. I think it's a really interesting field that's going to keep growing. So I thought this case would give us a lot of good discussion points.
I think they have many connections, but it's hard. It's not my best opinion that they are necessarily part of the same disease. Scleroderma has a vascular feature which is very prominent, and then fibrotic feature. And if you think about classical lupus, the vascular part could be there. They can have Raynaud's, but the fibrotic skin fibrosis is not certainly part of lupus. Now they can have overlap. They can be overlap syndromes, better said. But I will have a harder time arguing that are part of the same illness spectrum classically.
Thanks,
Thank you,
everyone.
everyone. Okay.
Stop recording.